The impact of preoperative stoma marking is profound on the life of an ostomate. In 2016, 120,000 people underwent fecal and or urinary diversion in the US and Canada. Stoma site marking was found to be one of the most impactful services provided by the wound ostomy continence nurse. Stoma site marking, along with the pre-op education and ongoing care by a WOC specialist, had a positive effect on the post-operative period and a positive effect on the adaptation of the patient with their stoma. There are multiple factors that influence the outcome for a patient following ostomy surgery. There is the patient's ability to cope. There's the patient's sexuality. There's the patient's interpersonal relationships. Does the patient have a caregiver? Does the patient have a significant other? Is the patient a caregiver? Does the patient have young children? All of these together create this picture for what this patient is going through. Is the patient, does the patient leave the home to go to work, or does the patient stay home and work from home? Is the patient a housekeeper? Is the patient a personal caregiver for an elderly parent? What are the leisure activities? All of these factors influence whether or not the patient has a successful adaptation with their ostomy surgery. Preoperative teaching and stoma site marking increase the chances of appropriate stoma location and hence a successful adaptation to stoma care. The effect of a WOC specialist also enhances acceptance of a new body image. The WOC specialist also promotes self-care. One of my favorite things to say to a brand new ostomate when I meet them is, I'm going to teach you survivor skills, because when you go home, who is going to change this appliance if it leaks in the middle of the night? Are you going to lay in bed with urine, or are you going to take charge and either tell someone how to change it or change it yourself? Another effect of a WOC specialist is we promote self-management of complications. I strongly encourage patients to be proactive if they see some issues developing with their skin or if they're having issues with their ostomy. I encourage self-management. If the patient has complications that they can't fix, then I also offer them the ostomy clinic as a support for them. Patients receiving preoperative stoma marking have lower rates of anxiety and improved health-related quality of life indicators. Preoperative ostomy education contributes to shorter hospital stays and a quicker mastery of care. The quicker the patient develops the ability to care for their ostomy appliance independently or with their caregiver as a team, the more successful the hospital stay is, and the faster they get home and the faster they are happy and get back to their normal life. The WOCN Society and the American Urological Association has put forth a position statement on preoperative stoma site marking for patients undergoing urostomy surgery. This is a guideline to assist clinicians, and especially those who are not surgeons or wound ostomy continence nurses, in selecting an effective stoma site or placement. Now, when you talk to your physicians and you want to really advocate for the patient to have stoma site marking, this is a great tool to have in your toolbox. These are two well-respected organizations within the medical community and the nursing community, and it is something that you can use to show your physicians and say, this is a statement put out by these organizations to support this. Appropriate stoma site selection decreases complications such as barrier failure and peristomal dermatitis. It may influence predictability of pouch wear time and the ability of the patient to adapt to an ostomy and become independent. If a patient has an inappropriate stoma site marking and they have ongoing issues with barrier failure and peristomal dermatitis and have poor wear time, they're not going to be happy. They're going to be frustrated. And they're not going to have a successful adaptation, and they're going to struggle. There's going to be an increase to healthcare costs because either A, they have to purchase more product because they have run out. Number two, They have to have their insurance get more product to them. Or number 3, they might even wind up back in the hospital and be readmitted. And that no one wants to see. Preoperative stoma site selection also gives you the opportunity to select, to assess a patient in multiple positions. And this, by assessing them in multiple positions and really observing the abdomen as you go through these changes in life, this will really create for an optimal stoma site. When you do your preoperative assessment, you want to determine where the rectus muscle is, and that is where you are going to place the stoma marking. You want to put that stoma within the rectus muscle because that is one of the ways that we try to decrease the risk for peristoma hernia. Also, when you divide the abdomen into 4 quadrants, you are kind of helping correlate the topographical information to the underlying anatomical structures, which will help you locate the appropriate site. For example, a urostomy or the ileal conduit is usually placed in the right lower quadrant because a piece of the ileum is used, and the ileum is usually located in the right lower quadrant. Here is a schematic from that position statement that shows standing, sitting, and supine. When the patient stands, you want to look at the profile of the patient. You want to notice where the abdomen curves back under towards the body, and you want to avoid the underside of the abdomen, which is not visible to the patient. Once again, you want to look at that line of sight and avoid anything below that line of sight because the patient can't see. When the patient sits, you'll be able to note skin folds, bony prominences, and creases, and you want to avoid those. When the patient lies flat, that's when you determine where that rectus muscle is. If you can't palpate it by having the patient bear down, you can use the nipple line to move up and down the abdomen and kind of see where that rectus muscle is. That way is actually a good way to determine where the rectus muscle is in an obese patient.